team, shall I start?
Yeah, we are lined up. Please start.
Good evening, everyone. A very warm welcome on behalf of Linux Laboratories. Today, myself, Rajshri Gupta, Senior GM Marketing, is very delighted to share this chair and share this forum with the international speaker on novel antiepileptics. Today, Dr. Steinhoff is sharing his own clinical experiences and the uses of perampanel in the real world. So this lecture has been designed in order to create a much more excitement and knowledge about using this perampanel, the brand for Compa, in your practice. I welcome all the delegates on behalf of Linux Laboratories. Today's session is being moderated by the eminent Dr. Sangeeta Rao, professor and head of the Department of Neurology of the same SAIT GSM Medical College, Mumbai, and the KM Hospital, along with being a chief epileptologist at the KM Hospital. Dr. Sangeeta Rawat is going to introduce the eminent speaker for tonight, Dr. Steinhoff. Over to you, Dr. Sangeeta.
I welcome to all the participants and good evening to all. And it's a pleasure to introduce Dr. Steinhoff, who is a professor of neurology and clinical neurophysiology at University of Freiburg, Germany. He started his professional career since 1987, and he is currently medical director of Epilepsy Center Cork since 2002. He has been awarded the German Neurology Society Top 5 Lectures Award and also Alfred Hübner Prize in 2015. He is member of the German section of ILA, German Society of Clinical Neurophysiology, and corresponding member of the AES, American Epilepsy Society. He was co-chair in the Therapeutic Strategy Commission of ILA. He was past president of the Society of Pre-Surgical and Diagnostic and Surgical Epilepsy Therapy. He has been on the multiple anti-epileptic drugs clinical trials as a principal investigator. He is a reviewer in more than 35 journals. He has got immense number of publications, 292 original peer-reviewed art journals, in 224 Medline registered publications, 135 books, book articles, scientific comments, and 1,159 presentations or quotable abstracts. So a great, your CV is really impressive. And I think you have a great scientific background of your research, and we'll be really having a very happy to hear your personal experience with perampanel. We have been using it, but it's still initially few years we had a cost constraint, but now it has been available freely in India as the many companies are coming up. So it is now going to be an affordable drug for many patients. And now that it is affordable, definitely we would like to have a guidance from the experienced doctors like you who are using it and who have been involved in the research of this perampanel. So over to you, Dr. Steinhoff.
Yeah. Thank you very much, Dr. Wald, for this very nice introduction. I'm honored to give this lecture today, and now I'm approaching the most difficult step of the whole evening to share my screen, and I hope that this works.
It will. Fingers crossed.
It should, yes. So, are you able to see my screen?
Yes.
That is very helpful. Wonderful. Yeah, so thank you very much again. And it's my pleasure to talk a little bit during that lecture about perampanel as a novel alternative for the treatment of epilepsies. And I will focus on the personal clinical experiences and the uses in the real world. Here you see a picture of the center of the Epilepsy Center in Cork, where I'm the medical director since a couple of years. Now, the ultimate goal of epilepsy treatment, just to give a general introduction, is, of course, to achieve seizure freedom without any treatment emergent adverse events. That's what we always try in every single patient we treat who is suffering from epilepsy. And we do have a lot of developments in epilepsy therapy. And the question is always, what have we achieved so far? Here you see this a graph of the first and second generation anti-seizure medications, and this huge variety of new and newer and recently introduced anti-seizure medications, along with neurostimulation and especially along with epilepsy surgery as a very powerful and effective and wonderful treatment in some patients. Coming back to the 80s, and Dieter Schmidt, one of the most prestigious epileptologists we had in my country, he was claiming even back in 1983 that previously untreated epilepsies can be treated successfully in 70 to 80% of the patients. And the question apparently is whether or not we made a lot of advance with the recently developed variety of these newer drugs. That brings me back to the year of 2000 and the very, very famous study of Martin Brody and Patrick Kwan. And back in 2000, you all know that slide. We knew that if we diagnosed as epilepsy correctly, about 2/3 of the patients will benefit and have a sustained benefit from the first or second anti-seizure medication. But if that is not achieved, there are about 36% of patients who will be more or less difficult to treat and where the perspectives are not so good. And the question is whether that changed. And basically the same group published this paper back in 2018 with many of the recently introduced newer anti-seizure medications. And it's basically the same, that if you fail with the second drug, the next add-on drug, it's never zero, you know, but the chances to achieve sustained seizure freedom without adverse events is pretty miserable still. So we definitely need better perspectives and need more possibilities to overcome this problem in epilepsy treatment. And that leads me to perampanel, which is an exciting drug for several reasons. Well, first of all, and I will cover that with another slide, is that here we have a new mode of action. And then mode of action we were waiting for decades, and that is the anti-glutamatergic property of perampanel. And then it has some peculiarities in its pharmacokinetic profile, which makes it also pretty interesting, especially in the use of already a bit frustrated patients who still have seizures and try 2 or 3 or more anti-seizure medications. Now, to address the postsynaptic excitability is certainly a new horizon. Many of our drugs work, as you all know, at the presynaptic level, as if you consider the sodium channel blockers, if you consider the class that consists of levetiracetam or brivaracetam or pregabalin and others. And then we, of course, have the second level, which is basically, or in a simplistic way, the GABAergic level, where we address the inhibitory interneurons, and where drugs such as phenobarb or benzodiazepines, also vigabatrin, work and act. And this third level, the postsynaptic excitatory glutamatergic level, was not really addressed by the anti-seizure medications we had until perampanel was introduced. And that is, from a basic point of view, the fascinating perspective this drug brings into the world of epilepsy treatment. Now, the other point is the pharmacokinetic properties and the clinical implications. And I wrote that on that slide in bold letters, which is the most important point. Not to waste too much time with that. And that is a long half-life. This drug has a long half-life of 105 hours, and that makes it possible to use a once daily dosing in the evening. And since this drug certainly has sedating properties, this once daily dosing is very helpful, not only in terms of practicability, but also to overcome the sedating effect the drug has. And in fact, in patients with comorbidities like sleep disturbances, you sometimes have the chance to address the epilepsy, but also the sleep disturbances by the addition or by the application of add-on perampanel. Now, the other point which makes it interesting is the question whether or not we do have a broad spectrum drug here. And the answer is yes. And I will cover that during my lecture as well. Looking at the preclinical models, step back from humans, we know that perampanel is very powerful in many of those models. I do not want to speak about those in detail, but both in models of focal as well as generalized epileptogenesis, there are data that perampanel is very effective. And that is, of course, the major argument from the beginning on, thinking about a broad spectrum anti-seizure medication, which in fact it is. So I want to start with the pivotal trials briefly that were performed in patients with focal epilepsies, and which led to the labeling and introduction of perampanel. Well, in my country, back in 2012, so almost 10 years ago. And I had the honor and the pleasure to be one of the authors of this pooled analysis of the 3 pivotal phase 3 trials in patients with focal epilepsies. And what was shown in the phase 3 trials that addressed doses between 2 and 12 milligram was exactly what was predicted from the phase 1 trials, namely that in the range between 4 and 12 milligram, add-on perampanel was statistically superior versus add-on placebo, which was, of course, intended to show and was crucial for the labeling. And another aspect which makes it already interesting for the perspective of generalized epileptogenesis is that in these pivotal trials in focal epilepsies, there was a very high efficacy, especially against the focal 2 bilateral tonic-clonic seizures, among the range of 4 to 12 milligram as an add-on drug. And both concerning the median % change from baseline, which is shown here, but also concerning the responder rate, meaning the patients who had a seizure reduction of more than or at least 50%. And again, we see that there was a statistically significant superiority concerning all partial onset seizures, focal unaware seizures plus focal to bilateral tonic-clonic seizures, but especially also in focal to bilateral tonic-clonic seizures. Now, the next step was, before we come to the real world experiences, the pivotal trial concerning idiopathic generalized epilepsies. And that was published by Jackie French and others in Neurology. And that was one of the best, from a methodological point of view, one of the best trials ever in idiopathic generalized epilepsy. Why is that? Because the authors were really picky in defining those patients participating. And in the end, here you see the placebo and the perampanel arm. And in the end, from looking at the seizures, perhaps with the exception of these 2 people with, or 3 people with atonic and tonic seizures, really most of those patients fulfilled the criteria for idiopathic generalized epilepsy. This was an add-on trial with a maintenance dose of 8 milligram. And it nicely showed, and that changed the labeling, of course, that concerning primary generalized tonic-clonic seizures, there was, again, a statistically significant superiority over placebo. And also concerning the 50% responder rates. Looking at the adverse events in those placebo-controlled pivotal trials, the spectrum was pretty similar, both concerning focal and generalized epilepsies. Dizziness and somnolence were the leading adverse events in a dose-dependent manner. So most frequently seen in the high dose arm with 12 milligram in the focal epilepsies. And these were the leading side effects. And these are still the leading side effects if we consider real world experiences and practical life. So that leads me to the clinical experiences. And before I quote some of the real world studies, I would love to show you some illustrative case studies of some of my patients covering both focal and generalized epileptogenesis. And the first guy is Stefan. Stefan, I know him for a very long time. This guy was born in 1973, had an uneventful family history, and he has a porencephalic cyst after a peripartal hemorrhage with a consecutive severe and pronounced right side hemiparesis. He has a slight intellectual handicap. And when I happened to know him, he had daily focal motor aware seizures and weekly bilateral tonic seizures. And he already had status epilepticus 4 times in his life. His EEG, though we all know that in focal epilepsy, it doesn't tell us too much about the therapeutic effects of our regimens, was showing very regular, and I try to point that out, very regular lateralized sharp waves along with a background slow. And that was the situation. And I tried several drugs in a very high dose manner. And you can see that here. These are his anti-seizure drugs prior to perampanel, carbamazepine with a maximum dose of 2000 milligram, primidone, phenobarb, valproate, lamotrigine, and levetiracetam. And before I started perampanel, he had an off-label high-dose baseline treatment of 800 milligram lamotrigine and 4000 milligram levetiracetam. And the problem was, if I increased that further, he would develop side effects. So we needed another option because he still had seizures. And in this case, this possibility to add this small pill as a once daily dosing in the evening, also concerning compliance and adherence, was of course an interesting fact. And the other one thing is that his mother was very interested to try a drug with a new mode of action. And that's what we did. So the ongoing seizures, the tolerability problems of the baseline medication, this easy to add mode, and the new mode of action were the basic arguments. So back in 2013, a long time ago, we started perampanel and up-titrated it to 4 milligram. He had no more bilateral tonic-clonic seizures, but still around 2 focal motor aware seizures per month. And then we increased it to 6 milligram. And he's seizure-free ever since 2013. I've seen him every year, and he has no side effects. But we also did not reduce the baseline medication. I always argue with the mother and with him that we could reduce the baseline medication, but they are so happy that they refuse that, as in many other instances of epilepsies like that. And so he stays on the medication I told you. But his EEG is very, very nice. Although I have to point out again that this the value of EEG in focal epilepsy concerning the therapeutic effects is certainly limited. I want to show you another very recent patient. He's exactly my age, born in 1961. So he just turned 60 as I did. And he has a very, very active epilepsy ever since. And this is almost with exclusively sleep-related hyperkinetic seizures. You all know these difficult to treat patients. We did EEG, we did long-term video EEG, we did pre-surgical diagnostics. He's a non-lesional case. You don't see too much in the EEG as very often in those frontal lobe epilepsies. So he's not a good surgical candidate. He has several seizures every night for decades, but still he has no intellectual deficits. And I admire him because he was full-time working all the time. His anti-seizure medications prior to perampanel comprised a lot of drugs like phenytoin, valproate, clonazepam, carbamazepine, levetiracetam, lacosamide, lamotrigine, and recently eslicarbazepine acetate. And his anti-seizure medications prior to perampanel was consisting of lamotrigine 500 milligram and eslicarbazepine acetate 1200 milligram. And this was taken by him peculiarly once in the evening, the whole dose. I saw him last time this year in June. I put him on perampanel in 2020 on 6 milligram add-on, and he's completely seizure-free. You don't see that too often, I have to admit that, but this is a miracle case and shows us how effective a drug like that can be. Eslicarbazepine is discontinued already, and meanwhile, and I would give not my right hand, but a left hand to understand why we have patients like this, like these dramatic responders, and others do not respond at all, although the phenotype of the epilepsies is completely identical. And the third case I want to cover briefly is Thomas. Thomas has an idiopathic generalized epilepsy, which is drug resistant, and that happens from time to time. And if we do have difficulty to treat idiopathic generalized epilepsy, it's not so easy because the variety of drugs we have for those idiopathic generalized epilepsies is pretty limited. This was his EEG, and in generalized epilepsy, of course, the EEG tells us something about the clinical condition of the patient. So the anti-seizure medications, when perampanel was added, consisted of topiramate 300 milligram and lamotrigine 600 milligram. We up-titrated perampanel beyond 8 milligram, as in the maintenance doses of the pivotal trial, but to 12 milligram. And since then, he had no more generalized tonic-clonic seizures, no side effects, and his EEG is normal. He still had absent seizures, but we added again ethosuximide because that was powerful in his childhood. And now he's almost seizure-free, including absent seizures. So the next part of my lecture of tonight is the part about the real-world studies, observational trials. And I may consider briefly what do randomized controlled trials show and what are they designed for. Do not forget, this is basically for the labeling. So we investigate short-term efficacy and tolerability versus placebo. Okay, but what do patients and physicians expect from a new drug? Sustained efficacy, no chronic toxicity or adverse events, and positive impact on comorbidities, and certainly an improved quality of life. And you can't measure that with the pivotal trials that cover maintenance periods of 10 weeks, 12 weeks, something like that. So we can learn something from real-world studies about long-term efficacy and tolerability, about the experience with the interactions and their impact, the impact on comorbidities, the real-life experience in patients who would not have been recruitable in randomized clinical trials, because the exclusion criteria in those trials are pretty strict. So all our patients with comorbidities, all our patients with signs of focal and generalized epileptogenesis are not included. And we start to learn after the labeling in patients like that. We may detect rare but important idiosyncratic adverse events if you reconsider the story with vigabatrin or with felbamate. And these studies may help to define the profile of the best suitable candidates for a given new anti-seizure medication. So this is a variety of real-world studies with perampanel, and I just want to pick some of them because I think these were considerably and especially helpful. And the first one is this very recently published study of Vicente Villanueva, who was one of many co-authors, and the strength of this study is the number of patients. So this is a pooled analysis in patients with focal epilepsy, and we investigated the retention and effectiveness after 3, 6, and 12 months and at the last visit. And it covers, as I said, more than 5,000 people with epilepsy. Concerning retention, it's 4,700 that could be used for the analysis, and the 3-month retention rate was 90%, 6 months 79%, and 12 months 64%, with a mean retention time of 10 months. Effectiveness, well, the more than 50% responder rate after 12 months was 58%. After at the last visit was 50%. And if you consider that most of those patients were difficult to treat epilepsy patients, it's quite promising that the seizure freedom rate at the last visit was 20%. And some of the patients suffered from status epilepticus and were included in that observational meta-analysis, and a responder rate of 50% in status epilepticus is certainly quite promising, although I have to point out that my personal experience with status is really limited. Looking at safety, about 50% of patients had adverse events, and as I said previously, dizziness and somnolence are the leading adverse events in most patients, which can be overcome in many of those patients by this once daily dosing in the evening, like a sleeping pill, you know. And but side effects such as irritability or behavioral side effects certainly occurred as well. And I always claim that experienced doctors and experienced epileptologists should be able to overcome that by their experience. And if side effects like that happen, one should probably consider to go for another anti-seizure medication. The second real-world study I want to cover is this one, the PHI-DATA study, again from Vicente Villanueva, because I learned a lot out from that study, and this is the crucial slide. The crucial slide is that they could show that if we up-titrate outpatients even slower than recommended, namely every 2 milligram every 3 to 4 weeks, the number of adverse events is reduced clearly and significantly. And if we consider this group of difficult to treat patients, if they have side effects in the beginning of the titration, they will discontinue, at least in my country. And therefore it's worth to follow this regimen of a slower titration, because the patients do not care whether they have a good effect, a good efficacy after 8 or after 12 weeks, but they do care whether they have side effects in the beginning, and that is a crucial factor. And if they discontinue prematurely, we may overlook a good efficacy. And the second point why this up-titration this slow up titration is good and important is this one, because we do know that we have low dose responders. And this was shown by the study of myself, which is a post hoc analysis of the pivotal trials, but my personal experience is just the same. So if we up titrate too fast, we would overlook the low dose responders. And these low dose responders are the most interesting patients for me, because it is tempting to speculate that these are the patients susceptible to the unique mode of action of perampanel. And we had a closer look. I have a huge therapeutic drug monitoring lab in my hospital, so we had a closer look whether or not the plasma concentrations tell us something. And it's not necessarily the case. We saw a huge inter-individual range. In the black columns, you see the responders. In the white columns, the non-responders. And again, we see that we had a lot of responders at low serum concentrations, meaning at low doses. And there are individual therapeutic ranges and not so-called general therapeutic range, and low plasma levels may be sufficient in certain patients. On the other hand, we have to consider that the serum concentration of perampanel is clearly influenced by the baseline medication. And if the baseline medication consists of potent enzyme inducers, and that is from the pivotal trials again, we still saw that in patients who had inducers, there was a statistically significant superiority over placebo, but this effect was not as pronounced as in patients without inducers, and these were fixed doses. And that means that in patients who are on enzyme inducers and where you do not have a reasonable efficacy of perampanel, tolerability provided, it may be correct and appropriate to increase the dose. And in my personal experience, which is off label, in some patients even beyond 12 milligram. And I just got an email today from a patient of mine who is unique because he's on 28 milligram, but he's a very special and a rapid metabolizer, but he benefits. So, coming back again to Kwan and Brody and coming back again to the Chen study, there's this question about the efficacy of an add-on regimen in the course of the treatment. And very apparently, of course, you have higher chances to be successful the earlier you give a given anti-seizure medication. That is also true with perampanel. So this real-world study from Spain shows the experiences with early add-on treatment. So not as the 9th or 10th anti-seizure medication, but as the first or second add-on perampanel. This was a multi-center prospective observational study to investigate the effectiveness of early add-on perampanel in 113 patients with focal epilepsy, where perampanel was given at the first add-on in 1/3, and as the second add-on added to a combination of 2 anti-seizure medications in 62.8% of patients, with a mean daily dose of 6 milligram at month 12. At 6 months, the 50% responder rate was 50%, 20% was seizure-free, retention rate was 80%. At 12 months, 50% responder rate was 68%, 26% was seizure-free, and the retention rate was still 80%. And the percentage of seizure-free patients was significantly higher in patients where perampanel was used as the first add-on. So that is not specific for perampanel. This is specific for the experiences in epilepsy treatment, as I said previously. And but since this is a powerful drug, one might consider in some clinical circumstances to use it pretty early in the course of the treatment. Adverse events were seen in 30% in this trial, with irritability and dizziness being the most frequent ones, mostly mild or moderate. And in this slide from the same paper, we see that perampanel was effective in both patient groups, but certainly more effective in this group where it was used as a first and not as a second or third add-on. And this is another single center retrospective study from Italy, which is pretty interesting, although the numbers of the patients are pretty limited. And that was an first add-on trial, levetiracetam versus perampanel. And looking at the responder rates, comparing perampanel and levetiracetam, there was not a big difference concerning 75% responder rate and seizure freedom. They were almost equal, and levetiracetam was there was a tendency for levetiracetam to be a little bit more efficacious. But looking at adverse events, very interestingly, this was the opposite. And this was very, very important for the outcome, because there were significantly more treatment discontinuations due to adverse events with levetiracetam compared to perampanel. And there was a significantly higher retention rate as a result under perampanel compared to levetiracetam. I certainly do not claim that perampanel is better than levetiracetam. You could never say that from a one single center study, but the adverse events of perampanel are apparently not that dramatic as some people thought when this first antiglutamatergic anti-seizure medication was introduced. And finally, I think as the last real-world study I want to show you, and addressing the broad spectrum again, this is a real-world study that covers patients with idiopathic generalized epilepsy. And perampanel was initiated in those patients prior to December 2016. And the observational time was 12 months in 149 patients from 21 centers. These are the demographic data of these patients, and you can see that majority of patients suffered from juvenile myoclonic epilepsy or idiopathic generalized epilepsy with exclusive generalized tonic-clonic seizures. And these are the results. Efficacy after 12 months in 115 patients with primary generalized tonic-clonic seizures, 62% seizure-free, 75% more than 50% responders. There was a 77% mean reduction of monthly seizure frequency compared to baseline, an 83% retention rate after 12 months for all patients, and a 59% seizure freedom rate for all seizures, which is pretty promising. Again, and these are the side effects in this study in patients with idiopathic generalized epilepsy. Psychiatric side effects like irritability was the leading one. I don't know whether this is specific for idiopathic generalized epilepsy or not, but more important, more than 90% of the adverse events were mild or moderate. There was a tendency towards more frequent psychiatric adverse events in patients with psychiatric known comorbidity than without. No wonder. And some patients had weight gain, which sometimes is an issue if you treat patients with add-on perampanel, no question about that. So in the last part of my lecture of today, I was asked by the organizers to discuss a little bit the pros and cons of perampanel and other new anti-seizure medications. And of course, I will do that as balanced as possible. But I want to point out that this is now totally my personal experience and nothing else. Well, so clobazam. We have clobazam in Germany as an anti-seizure medication for more than 25 years. But clobazam has the pros and cons of a benzodiazepine. It is certainly powerful. We don't give it too often in patients according to a chronic schedule, because we do see the problem of tolerance and we do see the problem of addiction. So in my country, it is not very popular, although it's a very powerful drug. Lamotrigine is, in our guidelines, along with levetiracetam, the first-line drug for focal epilepsies. And this is due to the very, very good tolerability profile. I think lamotrigine is another story if we combine it. Not with valproate. We all know that valproate plus lamotrigine is extremely effective, but sometimes tremor-related associated combination, but in combination with enzyme inducers, in combination with other sodium channel blockers, it's not that helpful. For me, it's a monotherapy drug. Oxcarbazepine is extremely effective in focal epilepsies, no question about that. We have the drawback of the enzyme induction, which makes it difficult in female patients who are on the hormonal contraception that doesn't work together with oxcarbazepine. And the second issue concerning tolerability is, of course, hyponatremia. But it's very effective. Lacosamide is a clear progress because here we have a non-enzyme inducing sodium channel blocker with a very predictable safety profile, and therefore lacosamide has a clear role in the profile and in the spectrum of the anti-seizure medications nowadays in my country. And in Germany, they just got the additional labeling for idiopathic generalized epilepsies as well. So lacosamide is certainly an interesting drug, especially because you have the intravenous formulation as well. And finally, brivaracetam, the little sister of levetiracetam, if you want, certainly a good addition and a powerful and well-tolerated drug. It is like the complementary addition to the armamentarium. We have complementary to perampanel. Perampanel is a drug with a long retention half-life, elimination half-time, and brivaracetam is the opposite. So with perampanel, we need a couple of weeks or months until we know enough about efficacy and tolerability. Brivaracetam is a drug where we know that within days if patients have frequent seizures. If we switch brivaracetam from levetiracetam, it's more for tolerability reasons. More than 1/3 of patients benefit from that if they had psychiatric adverse events with levetiracetam. If we switch from levetiracetam due to efficacy reasons, our CORC experiences are less favorable. So we don't have too many patients who really benefit concerning the seizure frequency when we switch them for that reason from levetiracetam. So coming back to my final remarks here, perampanel is certainly a very powerful and promising addition to our armamentarium. It's a peculiar and unique drug with a unique mode of action. And since the efficacy of anti-seizure medication has not improved markedly over recent decades, we are very happy to have here a broad spectrum new anti-seizure medication with a unique mode of action. The earlier it is applied in the course of the treatment regimen, the better is the potential response. There may be comorbidities or special situations like sleep disturbance or sleep-related seizures where I personally use it pretty early. And start low, go slow is always good in epilepsy treatment, especially also with perampanel. But we should dose consequently and not give up too early in patients who may not benefit at low doses. If they tolerate low doses and we do not have the efficacy we wanted to have, it is certainly a good idea to further increase the dose until we get an appropriate effect. So thank you very much for your attention, and thank you very much for the a kind invitation to give this lecture late in the evening in India. Thanks you.
Yeah, thank you very much, Dr. Steinhoff. It was an excellent talk, and I think it really gave us a good insight into the perampanel. And I saw that there are good results with JME, and that's where I think we are really looking forward to the because we have got many additional for the focal epilepsies, the newer drugs, but something like IG. We really have problems in uncontrolled IG, refractory IGs, and I think here the perampanel will definitely help us. And I think there are many questions, and I think over to Rajeshri for question answers from the host.
Yes. Good evening once again. Thank you, Dr. Steinhoff, and thank you, Dr. Rawat, for sharing your valuable time and now we take over the questions. So as the questions have been posted on the live forum, Dr. Nataraj is requesting for an answer whether can perampanel be used as a first-line drug in focal epilepsy. So your answer.
Not according to the labeling in my country. It is possible in the US, to my best knowledge, because the FDA has another perspective, meanwhile, than the European agency. So in the US, it's labeled for monotherapy, and I could imagine that in some patients it would be very, very easy. Well, if you take me as a patient having the diagnosis of epilepsy and getting a once daily drug in the evening, why not, if it's powerful? But because we have the labeling we have in Europe, I do not have experience as a first-line monotherapy in focal epilepsy. But from the profile of the drug, no question that it might be appropriate.
Thank you for the response. Dr. Navajyoti Barakataki is requesting for answer on, is there any study of use of perampanel in WWE?
Well, if you tell me what WWE is, women with epilepsy.
Women with epilepsy, yeah.
Okay. I think there's no particular study addressing women with epilepsy with perampanel. Well, the experience in women is basically the same as in men. One problem, as with many new anti-epileptic agents, is that we do not have any teratogenicity data. Yes. At least as far as I know. So it's pretty difficult to address this in young females who want to get pregnant. And that is decided on a very individual base in my practice. But to answer the question briefly, there are no particular studies, to my best knowledge, in women with epilepsy.
Sure. Dr. Sanjay Mongia from Mumbai is requested for an answer whether can perampanel be used in patients with behavioral or psychiatric disorders and how safe it is.
Well, I showed you on one slide that the risk that patients have behavioral psychiatric side effects is higher in patients who have this comorbidity already. On the other hand, we have enough patients with these comorbidities who benefited. So for me, it's not a contraindication, but it clearly means that we have to speak about the possibility with the patients and also with the relatives, and that we have to be careful. But I pointed out already that if we are experienced enough and if we spoke about this possibility, we should be able to observe that in time and then to draw the right consequences. And perhaps I can cover the first question here by that, because if we do have the clinical situation where we want to down titrate or discontinue perampanel, we always, and we published that as well, we always did that rapidly, abruptly, because due to the long half-life, no matter whether it's 2 milligram or 12 milligram, we always discontinued it abruptly, because if you measure the serum concentrations after the abrupt discontinuation, you still measure serum concentrations after 2 to 3 weeks if you do that. So discontinuing step by step would mean that this is a discontinuation over months, and you don't want to have that.
Yeah, at the same time, can I just add thing? At the same time, add another drug to control the seizure.
Yeah, of course.
Yeah, and then, because then can't stop abruptly. I think that's what is the ideal thing, I think.
In continuation to the long half-life, Dr. Animesh Gupta from Lucknow asks whether is there any protocol for the patients, since the drug half-life is long. So is there any protocol if a patient develops severe side effects of perampanel therapy?
Well, I'm not aware of a protocol that is formulated. We a couple of years ago, Eugen Trinker and I and some others published one of those expert opinion papers. Whether they really add very important information is questionable, I have to admit. But well, as I said, in that case, we would discontinue abruptly anyway. And if there are severe side effects, for example, from the behavioral side, we sometimes need additional drugs addressing that. And we have to cover that as professional as possible. But I'm not aware of a guideline.
Sure. We are having more questions. So one question is arrived from Dr. Sheikh Nawaz. How useful is the drug in post-stroke seizures?
I would say as useful as in all other seizures. So there's no specific difference.
All right. Any ideal drug for non-responding patients, as asked by Dr. Arvind Kumar?
With strength.
Strength is ideal.
Is the ideal for non-responding patients. Well, as always in epilepsy treatment, if a patient tolerates the drug and has no effect, I would increase the drug until I have an effect or I have adverse events. If I have adverse events and it doesn't work, it's a wrong drug. But there's not a general rule for that or general dose for that. That is very individual.
Right. Dr. Zico de Cost asked whether it is safe to use in pregnancy and lactating mothers.
We do not have enough data to answer that question. I have exactly two, in my personal experience, have exactly two patients who were pregnant and had kids, and everything went fine in those two cases, but this is not a statistic. So we need more figures on that, and therefore it's too early to answer the question.
Actually, eagerly waiting for BRAVE and this both perampanel for a teratogenic, side effect, because really waiting, yeah.
You are totally right. We're waiting for perampanel, brivaracetam, lacosamide, eslicarbazepine, name it. We were waiting for teratogenicity data in ethosuximide, which was introduced in Germany in 1958. And we are waiting for zonisamide, which was introduced in Japan in 1989. That's a nightmare.
Absolutely.
Thank you for that insight. Dr. Bhoi is asking what is the average higher dosage needed?
Well, same answer as previously. The average higher dosage needed is, I would say, around 8 milligram, but that is not, this is just a personal guess. I would say if you have a patient on 8 milligram and does not have any effect, well, we do increase further, but I would think that the percentage of patients who will then benefit from higher doses is pretty low.
Sure. And how rapidly can you down titrate?
I think the sir has already covered that, I think.
Oh, yes. So coming to a question from Dr. Paresh Kumar from Cuttack, he has many questions. So one of which I'll ask as of now: how confidently can we prescribe perampanel to an OPD patient with whom we can't follow up as compared to indoor patients?
We can.
Yeah, well, as with any other drug, it's not a very comfortable situation if you cannot follow him. But I don't see a difference between perampanel and other anti-seizure medications. It's just a not very delightful treatment situation.
And aligned with many other questions, have you any opinion on its drug adverse interactions with any other first line or second line ADs?
Well, yeah, of course. Well, I mentioned the problem with enzyme inducers. So enzyme inducers do have an impact on the serum concentration of perampanel, and that might have a negative impact on the efficacy. But this is basically the only adverse interaction I'm thinking about.
And can I just ask you, Dr. Steinhoff, what do you think of, Dr. Steinhoff, I just wanted to ask you, what do you think of the combination with levetiracetam? I mean, I'm really skeptical because both have a behavioral side effects, you know.
Yeah, that's true, but we still do it, and I don't see.
Yeah, I also do it
because, you know, I think the mechanism is different. So
yes.
It is not really possible to foresee problems with perampanel if you had problems with levetiracetam. So we still do it, and for me, it's not a matter of contraindication or whatever or concern.
Okay.
I'll take the last question. Dr. Mandeep Singh Kataria from Mohali. He has asked, when or for what indication should we switch a patient on established and cheaper pre-existing broad-spectrum antiepileptics to perampanel? This is the last question I'll take.
Well, if the treatment doesn't work, well, if the patient has still seizures, if the patient is on valproate and has a weight gain of 40 kilograms and hair loss and tremor, so if we have an unsatisfactory ongoing sustained treatment situation, that is the indication for a try with perampanel.
That's really good. I think with these, the questions have been very interestingly answered, and I thank Dr. Steinhoff for his patience and time that he has given to our session, which is brought on behalf of Linux Laboratories. Before I sign off with Dr. Steinhoff, any last words from Dr. Sangeeta Rawat, and then I take over on our discussion before we close the day.
No, I think we really had a very nice talk, and the real world data was very interesting because that gives us more and more confidence in using this drug in all types of patients. So I think we really enjoyed it. Thank you very much. And I think we had a great panel discussions also and a great questions also. Thank you, Rajeshri.
I thank you very much as well.
Yeah.
Thank you very much. So once again, on behalf of Linux Laboratories and the team Linux, we are very glad to share that perampanel in India is brought in the name of Percompa. The brand is Percompa from Linux Infina team. Our team of sales managers and field staff is working towards sharing this brand and making it available for your patients and for your use on your daily routine practice. Thank you very much to all the viewers. I would also like to share with you that on behalf of Linux Infina, we are taking more steps forward in getting closer to the community and trying to build a better community awareness on the in epilepsy. And we are going to shortly introduce to you a virtual purple ribbon chain that we are bringing forward in order to build more awareness on epilepsy coming month of November, falling on the Epilepsy Awareness Month. We'll share with these details to you shortly. We'd love you to have you registered and be part of the Asia's largest virtual purple ribbon chain. Before I sign off, during the registration, we had requested a lot of participants who were eager to share their questions, and Dr. Bernard himself has selected a few of the questions proposed by the registered and participants of today's program. So we've got about 800 approximately participants in this lecture today. Dr. Kala Hemant Kumar from Andhra Pradesh, who had asked the question on pregnancy presented with refractory seizures, has been announced today's winner. Dr. Mary from Kerala, who has asked the question on additional role of perampanel in NMD receptor-related diseases like encephalitis and how it can influence the behavioral problems, has also been selected as a winner number 2. Dr. M. Sarvanan from Tamil Nadu, Chennai, who has presented a case discussion related to neural tube defect and patient with refractory GTCS being treated with sodium valproate and Perform the brand, and which has been the preferred drug by which could be the preferred drug, is selected as the question number 3. And lastly, Dr. Gaurav Kasundra from Mumbai, his question on role of novel anti-epileptic drugs in treatment of epilepsy like LGS and its specific genetic syndrome like women of childbearing age with juvenile myoclonic epilepsy intolerant to levetiracetam. So congratulations to all the participants and the question winners, and we'll shortly reach out to you with your winning award that will be presented by Team Linux in FINA. So with this, we bring this session to the end. I would once again like to thank each and every delegate present today here that has made this evening very enriching, very delightful. And Team Linux in FINA is very proud to share this forum once again with the chair of Dr. Bernhard Steinhoff, as well as Dr. Sangeeta Rawat, who has given their time and valuable discussion and made this evening a very wonderful experience to all of us. Once again, I request you all delegates to support the brand of Percompa, and thank you all for joining in today. So a very good evening, and please, thank you.
Yeah, thank you, Dr. Steinhoff. Yeah, thank you, Rajashri. Yeah, okay. And thank you, Linux.